You've been doing everything right. You cut the processed food, you started walking, seriously walking, not just around the block. You traded the wine for sparkling water most nights. You tracked your sleep, managed your stress as best you could, and still, the scale barely moved, or it moved backward. And the frustrating part isn't just that it's not working. The frustrating part is that the same things that worked for you in your 30s simply don't work anymore. Same effort, different result. And nobody gave you a manual for that. And somewhere in the back of your mind, a thought crept in that you'd never say out loud. What if I'm just broken? You're not broken, but you are going through something that medicine is only now beginning to explain clearly. And today's video is about one part of that explanation that has been making headlines. A study from the Mayo Clinic looked at women using Tirzepatide, one of the newer GLP-1 medications, and found that the women who were also on hormone therapy lost more weight than the women who weren't. That's the headline. And if you heard that and thought, wait, does that mean hormones help you lose weight? You're asking exactly the right question, because the answer is more interesting and more nuanced than the headline suggests. This is education, not medical advice. What we're going to do today is slow that headline down. We're going to look at what the study actually found, what it doesn't prove, and why the real conversation isn't about a shortcut. It's about understanding what's happening in your body after 40, so you can have a smarter, more specific conversation with your doctor. Here's what we know for sure. Menopause is not just a hormonal event. It's a metabolic event, and the weight that comes with it, especially the belly fat, the shift in body composition, the way your metabolism seems to just stall, is not a willpower problem. It is a biological shift that researchers are still working to fully understand. To see why, it helps to understand what estrogen was actually doing for your metabolism all those years. Estrogen isn't only a reproductive hormone. It's deeply involved in how your body processes energy. It helps keep your cells sensitive to insulin, which means your body doesn't have to work as hard to move glucose out of your blood and into your tissues. It influences where your body tends to store fat, favoring the hips and thighs over the abdomen. And it plays a role in preserving lean muscle mass, which is one of the primary drivers of your resting metabolic rate. When estrogen levels fall during perimenopause and then drop more significantly after menopause, all of those protective effects weaken at the same time. Insulin sensitivity decreases, fat storage shifts toward the abdomen, muscle mass becomes harder to maintain, and the result for many women is weight gain that feels completely disconnected from their behavior, because in many ways it is. So here's the question I want you to sit with as we go through this video. If the way your body handles weight genuinely changes after menopause, does it also change how it responds to certain treatments? That's the real question the Mayo researchers were trying to answer. And the answer, it turns out, is possibly, but the details matter enormously. Let's start with Tirzepatide and why it's different from what came before. Tirzepatide, sold under the brand names Zepbound for weight management and Mounjaro for type 2 diabetes, works differently from the first wave of GLP-1 medications. The original GLP-1 drugs activate one receptor. Tirzepatide activates two, the GLP-1 receptor and the GIP receptor. GIP stands for glucose-dependent insulinotropic polypeptide, which is a mouthful, but what it does is important. GIP affects how the body stores and processes fat, how it responds to insulin, and how efficiently it burns energy. In clinical trials, the dual action of Tirzepatide produced greater weight loss than single receptor GLP-1 drugs in head-to-head comparisons. In some of those clinical trial participants, weight loss reached 15 to 20% of body weight over a year or more, though results varied significantly depending on the individual, the dose, and the level of clinical support involved.
That is a meaningful range. And it's worth understanding what it does and doesn't tell us about any one person's experience. And here's where the connection starts to get interesting. After menopause, estrogen levels drop significantly. When estrogen drops, that metabolic protection weakens, and many women experience a shift toward more insulin resistance, more visceral fat accumulation, and a slower metabolic rate. So you have a medication that may work especially well in the presence of insulin resistance, and a population of women who are experiencing more insulin resistance than they were before. That overlap is exactly what researchers at Mayo were paying attention to. So the question they were exploring was essentially this: if a woman is both on Tirzepatide and on hormone therapy, essentially restoring some estrogen into the equation, does that combination do more than either would alone? Does the hormonal environment change how well the medication works? Their answer, based on the data they analyzed, was yes. In this group of women, the women on both lost more weight than the women on Tirzepatide alone. Now, and this is the part that separates a careful conversation from a misleading headline, this study was observational. That's a specific and important word. An observational study watches what happens to a group of real patients. It does not randomly assign anyone to a treatment group. It does not have a placebo control. It cannot prove that hormone therapy caused the extra weight loss. What it can show is that the two things appeared together, and that the association was strong enough to be worth paying attention to. Here's a useful way to think about it. Imagine researchers notice that cities with more libraries tend to have lower crime rates. That's an association. It doesn't mean libraries cause low crime. It might mean that cities that invest in libraries also invest in schools, parks, and community programs, and that's what's actually driving the outcome. The association is real, the cause is more complicated. The Mayo study works the same way. The association between hormone therapy and greater weight loss on Tirzepatide is real. What it means, the mechanism, the cause, is not yet proven. So why does it matter? Because it points to something that researchers have suspected for a while, that the hormonal environment a woman is in may genuinely affect how her body responds to metabolic treatments. And if that's true, it means that a conversation about GLP-1 medications for a postmenopausal woman might need to include a broader discussion about her hormonal health, not just her weight or her blood sugar. Have you ever wondered whether your doctor is looking at your weight and your hormones as separate problems when they might actually be part of the same picture? That's not a criticism of any doctor. And here's something worth understanding about why that separation happens in the first place. Medicine has historically been organized into specialties that don't always talk to each other as fluidly as patients need them to. Gynecology handles the hormones, primary care handles the weight, endocrinology handles the blood sugar. Each of those clinicians is doing their job well within their lane, but your body doesn't work in lanes, it works as a system. And the research is starting to point towards something more integrated, a recognition that for women after 40, the hormonal picture and the metabolic picture are often the same picture, just viewed from different angles. Let's be specific about who this conversation actually applies to, because one of the most common problems with health headlines is that they reach everyone, but the underlying evidence applies to a much narrower group. The women in the Mayo study were postmenopausal. They were using Tirzepatide for weight management, and they were already on hormone therapy, meaning a clinician had already evaluated them, reviewed their health history, assessed their risks, and made a deliberate decision that hormone therapy was appropriate for them. That's a fairly specific clinical portrait. Hormone therapy is not right for every woman after menopause. There are well-documented contraindications, certain types of breast cancer history, certain clotting disorders, cardiovascular risk factors at specific levels. The decision to use hormone therapy is one that requires a careful, individualized clinical evaluation. It is not something you add to a regimen because a headline suggested it might improve your results on another medication. So if you're thinking, great, I'll ask for hormones so my GLP-1 medication works better, that's understandable, but it's not quite the right frame. The question isn't, how do I optimize my medication? The question is, what is my full metabolic and hormonal picture right now? And what combination of approaches makes sense for my specific situation, my specific history, and my specific goals? That's a harder question to ask, but it's also a far more useful one. Now let's talk about what Tirzepatide does and doesn't solve, even under the most favorable conditions, because this is where a lot of the coverage got genuinely incomplete. GLP-1 medications, including Tirzepatide, work primarily by reducing appetite, slowing gastric emptying, and improving insulin sensitivity. They are powerful tools, and for people with obesity-related metabolic risk, meaningful weight reduction can translate into real improvements in blood pressure, blood sugar, cardiovascular risk, and joint health. That is significant and worth taking seriously. But here's what they don't fix. They don't rebuild muscle mass. In fact, some research suggests that a portion of the weight lost on GLP-1 medications comes from lean mass, not just fat, which is a concern for postmenopausal women who are already losing muscle mass more rapidly than they were in earlier decades. They don't reverse bone density loss, which accelerates significantly after menopause and increases the risk of fracture over time. They don't address the sleep disruption that affects a large proportion of women in perimenopause and postmenopause. They don't resolve hot flashes, cognitive fog, and the mood changes that many women experience during this transition. And when people stop taking them, which many do, because of cost, because of side effects, or because of supply issues, the weight often returns, sometimes quickly. This matters because the menopause experience is not a single problem. It is a convergence of several things happening at the same time. Hormonal shifts, metabolic changes, bone health changes, cardiovascular risk changes, sleep disruption, and often significant psychological and emotional transitions that don't always get acknowledged in a clinical setting. A medication that addresses one piece of that picture, even very effectively, is not the same as a comprehensive approach to all of it. When you think about what you want your health to look like in the next 5, 10, 20 years, is weight the primary goal, or is it one piece of something bigger? The reason that question matters is this: the best outcomes in menopause health research don't come from optimizing one variable. They come from women who are engaged with the full picture, who understand what's changing in their bodies, who have a clinician who takes their symptoms seriously, and who have access to a range of options rather than a single solution being applied to a complex situation. The Mayo study adds a potentially important piece to that picture. It does not replace the picture. One more thing worth naming here, and this is something that doesn't get said enough in health content. Many women in the years around menopause feel dismissed. Their symptoms are attributed to normal aging. Their weight concerns are met with generic advice about eating less and moving more, as if they hadn't already tried that. Their questions about hormonal treatment are sometimes deflected. Their cognitive symptoms are minimized. The fact that research like this is being done, that scientists are specifically studying the intersection of hormonal health and metabolic treatment in postmenopausal women, is itself meaningful. It reflects a genuine shift in how medicine is beginning to take this population seriously. And that shift is worth acknowledging, even as we hold the individual studies to appropriate standards of evidence. Let's bring this home practically.
If you are postmenopausal and you've been struggling with weight despite doing the things that used to work, here is what this video hopefully gave you: a better frame, not a prescription. The Mayo study suggests that the hormonal context you're in may affect how your body responds to metabolic treatments. That is worth knowing. It is not a reason to walk into your doctor's office and ask for a specific combination of medications. It is a reason to have a more complete conversation, one that includes not just your weight or your blood sugar, but your hormonal status, your symptoms, your history, and your long-term goals. Here are 2 specific questions worth bringing to that conversation. The first one is this: given where I am hormonally, whether I'm in perimenopause, postmenopause, or currently on hormone therapy, how does that affect how my body might respond to metabolic treatments like GLP-1 drugs if we decide that's a relevant option for me? That question invites your clinician to think about your metabolism and your hormones as connected systems, not separate departments. The second question is this: what would a full picture of my metabolic health look like right now? Not just my weight or my BMI, but my insulin sensitivity, my visceral fat, my cardiovascular markers, my bone density, and how those things are trending. That question moves the conversation away from the scale and toward the things that actually predict long-term health outcomes. Now, this video talked a lot about Tirzepatide, but it's important to say clearly, GLP-1 medications are one category of option for one category of patient in one set of circumstances. They are not the starting point for every conversation about weight after menopause. Lifestyle, sleep, movement, nutrition, stress management is still the foundation, not because it's a moral obligation, but because the research consistently shows that no medication works as well in isolation as it does alongside sustainable daily habits. There is also something worth addressing honestly about access. These medications are expensive. A monthly supply of Tirzepatide without insurance coverage can run several hundred to over $1,000. Coverage varies significantly depending on your plan and your diagnosis, and the experience of navigating that system, prior authorizations, step therapy requirements, formulary changes, is genuinely exhausting for many patients. If cost or access is a barrier for you, that is a legitimate part of the conversation to have with your doctor. There are manufacturer patient assistance programs, clinical trial opportunities, and in some cases earlier generation medications that address overlapping mechanisms at a fraction of the cost. You deserve to know those options exist. The study from Mayo is promising. It opens a door. It doesn't walk you through it. Looking at everything you've heard today, what is one question you didn't know to ask before that you'll bring to your next appointment? That's the real takeaway. Not a medication name, not a treatment protocol, a better question. Because better questions lead to better conversations. Better conversations lead to better care. And better care, specific, informed, unhurried, respectful care, is what women navigating this moment in their lives genuinely deserve. Everything in this video is for educational purposes only. This is not medical advice. Tirzepatide, hormone therapy, and all other treatments discussed require individual clinical evaluation. Results vary significantly between individuals. If you have questions about your health, your symptoms, or your treatment options, please speak with a qualified healthcare provider who can evaluate your full personal history.